Hello everyone, in this video we will discuss about testicular tumors. This is the part first of the video. Going to the classification. The classification includes there is germ cell tumor and there is sex cord stromal tumor. The germ cell tumor can further be divided into seminomatous tumor in which seminoma and spermatocytic seminoma are there, and then non-seminomatous tumor in which embryonal carcinoma, yolk sac tumor, choriocarcinoma, teratoma are there. And in sex cord stromal tumor, there are two tumors. That is the Leydig cell tumor and the Sertoli cell tumor. We will discuss in this video only about the seminoma and spermatocytic seminoma. Going to seminoma. Now seminomas, they are the most common type of germ cell tumor, and the peak incidence of this tumor is seen in the third decade of life. And these tumors, they almost never occur in infants. A identical tumor is also present in ovary. It is a counterpart of the seminoma seen in females, which is known as dysgerminoma. Seminomas and dysgerminoma both express OCT3, 4 and NANOG gene. Now going to the gross morphology. The gross morphology, the seminomas, they produce bulky masses. The mass can be even 10 times the size of the normal testis. And now typically the seminoma is homogeneous. It's gray white. It has a lobulated cut surface but is always devoid of hemorrhage or necrosis. The outer layer, that is the tunica albuginea, is not penetrated. However, sometimes extension to epididymis, spermatic cord or scrotal sac can occur. Now in this picture we can see, this is the picture of the test, the seminoma. The tumor is quite homogeneous. There is no hemorrhage or necrosis. It is lobulated. We can see lobules are present. It's lobulated. It's lobulated, and it's a homogeneous, well circumscribed mass. Now going to the microscopy, that is the histology. Now typically the typical seminoma is composed of sheets of uniform cell. Here we can see this is a septa. We can see there are numerous septa, uh, and there are seminomatous cells inside this. This is the tumor cells, and these are the septa, and the septa are now infiltrated by lymphocytes. So typically the seminoma is composed of sheets of uniform cells divided into poorly demarcated lobules by a delicate septa. We can see these are the septa, and these septa are now infiltrated by moderate amount of lymphocytes. This is a typical picture of seminoma. Now going to individual cell. The individual cell, the classical seminoma cell, is large, round to polyhedral. We can see this is we can take example of this cell. We can take example of this cell. It is polyhedral. We can see there are polyhedral, the margins. We can see they are. It is a polyhedral cell. uh, it has a clear or watery appearing cytoplasm. The cytoplasm is not eosinophilic, it is watery, it's clear, and in the center we have a central nucleus which can show one or two prominent nucleoli. This is a typical appearance of the seminomatous cell. Now going to spermatocytic seminoma. We will discuss the clinical features at the end, firstly discussing the spermatocytic seminoma. Now, although it is related to seminoma by its name, it is a distinct tumor both clinically and histologically, and it is an uncommon tumor, and it is less than 1 to 2% of all testicular germ cell neoplasm, and the affected individuals are very old. It is around over the age of 65 years, so it has no clinical resemblance to seminoma. Now going to the morphology, it is also distinct from seminoma. Grossly, it is soft, it has a pale gray surface, sometimes cysts are also present. And on the microscopy, there are three populations of cell. There are medium cells, there are smaller cells, and then there are giant cells. The medium sized cell, they are most numerous. They have round nucleus, eosinophilic cytoplasm, smaller has a very less amount of cytoplasm, and scattered giant cells are present, which can be uninucleate, which can be multinucleate. We can see in this picture, this is a picture of spermatocytic seminoma. We can see this is a smaller cell. It has a very less amount of cytoplasm. Then there are medium cells, which are most predominant. They have eosinophilic cytoplasm and a round nucleus. And then there are giant cells, which are very large in size. These can be uninucleate or it can be multinucleate. Okay, now going to the clinical features of uh, seminoma. uh, Mostly it presents as a painless enlargement of testis. Now, any solid testicular mass should be considered neoplastic unless proven otherwise. Because of this, firstly, the biopsy of testicular neoplasm is not done because of risk of tumor spillage to the skin. If we will take a sample using a biopsy needle, the tumor cells can spread to the skin. So biopsy is not done. So if there is a painless enlargement of testicular testis, then standard management in that case is radical orchidectomy based on presumption of malignancy. So, any solid testicular mass is considered neoplastic unless and unless proven otherwise. Now, going to the mode of spread. Mode of spread is mostly lymphatic, and also lymphatic. It mostly spreads to the retroperitoneal paraiotic nodes, and hematogenous spread can occur to lungs, liver, brain, and bones. Now, lastly, we will discuss the staging, the testicular tumor. Now, in stage 1, the tumor is confined to the testis, epididymis, spermatic cord. In second stage, the tumor is confined to the retroperitoneal nodes, and this should be below the diaphragm. Lastly, the stage 3 is either outside the retroperitoneal node or above the diaphragm. This was about the staging. Now going to the uh, treatment. Treatment of the seminomas is mostly radiotherapy because it's a very radio sensitive tumor. It almost disappears after radiotherapy, so it has a good prognosis. And also spermatocytic seminoma also has a very good prognosis. This was all about this video. Do like, share, and subscribe. I will discuss this other testicular tumor in the second part. Thanks for watching this video.